So I'm going to today focus on talking about women's heart health. I put these paintings here because I would like to talk about women's cardiovascular health in 3 different stages. When they are in their reproductive age, inner layer, the youngest women, and the middle layers are undergoing perimenopausal symptom, surgically or natural menopause. The outer layers are older or post a few years, at least a few years post-menopause, and what to do. I would like to talk about the menopause first, then later briefly talk about the pregnancy-related cardiovascular risk. Almost 20 years ago when I was doing my residency, that's in mid-90s, women all use hormone because we all believe hormones are protective, at least to our own mind, how we look, how we feel, and perhaps to the heart too. So there are a lot of observational data all support this. The estrogen replacement, the abbreviation is ERT, hormone replacement, what it meant was estrogen and progesterone for women who have intact uterus, so that the progesterone would offset the risk of endometrial cancer caused by the estrogen. So all of these observational data support that using estrogen replacement and hormone replacement reduce the relative risk of cardiovascular disease. And the mechanism are twofold. It was thought to be twofold. One, the yellow part is plasma related. The estrogen increased, or hormone increased HDL, reduced LDL, reduced LP small a, and reduced LDL oxidation. You all know that oxidation of LDL matters more than the absolute number of LDL. And the plasma-independent mechanism directly, it protects the endothelium and dilate the vessel, increase the insulin sensitivity and reduce the coag factors. And most importantly, it reduced the arterial wall uptake of the lipid particle. And that's why even when you see some premenopausal women with pretty high lipid, you don't see them having as much event compared to postmenopausal women with the same degree of lipid. Because their endothelial health is better and the uptake of LDL is lower. So the largest data that it existed in the 1990s and early 2000s was the nurse health study. It actually started in 1976. It's not randomized because it's an observation study. It shows there are 40% reduction of cardiovascular risk and 50% reduction of all-cause mortality. After 5 years termination of the hormone replacement, the benefit is lost. And women with more cardiovascular risk factors have the greatest benefit. And women with natural menopause benefit more than those with surgical menopause. And here are the breakdown after 20 years of observation and follow-up. That's very powerful data because by that time, there are already 70,000 nurses in the observation group, and that's very powerful. And it showed that the lower the dose of the estrogen, the benefit is higher. When you look at coronary artery disease, at estrogen of 0.3 milligram, both heart and stroke event reduced. But when you increase the dose to 0.625, the heart event still is low, but the stroke increased significantly. And when you increase the dose to 1.25, then the stroke risk is really high. That is one of the reasons we say when you use hormone hormone to treat menopausal symptom, use lower dose, the lowest dose that can help your symptom. Then, since there are positive observations from the National Health, the Nurses' Health Study, then the first randomized trial on the heart disease benefit of, or the effect of estrogen or hormone on heart disease is F.A.C.C trial. The hormone replacement study is studied patients or women with heart disease already. So this is secondary prevention. So once upon a time, from the nurse health study, we felt that hormone is beneficial for heart disease. Of course, when the dose is higher than 0.625, the stroke risk is a lot higher. But heart disease is still lower. Then this happened. The F.A.C.C trial is the first trial randomized women with disease. And the design is similar to the F.A.C.C trial, the landmark trial for statin for secondary prevention, except replacing the Zocor with hormone in this trial. The average age of women is a lot older than the nurse health study, because the nurse health study, the women's age is between 30 to 55. The younger ones are the surgically menopaused women, and the older are natural menopause. They started the hormone because they have menopausal symptoms. But this F.A.C.C trial are older women who are already have disease and are at least 12 years after they have the menopause. So the reason why they use older women is that in randomized trial, you all know that you don't like crossovers. The more crossover, the more the data is getting contaminated. So they don't want younger women who are still having symptoms, and because of the symptom, they would oftentimes get off-label hormone just as a treatment, and they would ruin the data. So first was follow-up. It determines 4 years, and later, when at the end of 4 years, it shows some question of whether or not it's really protective, then the study extended, and that's the F.A.C.C trial. It's the same study, it's just observed or study lasts longer. And the primary endpoint is vascular death and MI. So those are heart endpoints, not DVT, not gallbladder disease. It's heart endpoint. And you can see the pink or orange line is the group of women or patient with heart disease randomized to hormone. Day 1 is 0. And by the end of first year, the cardiovascular event has increased significantly in the hormone group. And at that point, the study almost halted because it didn't reach the criteria of stopping the study prematurely. It continued. But by the end of year 2, the line crossed over. It appears that the hormone protects these women with heart disease compared to the women without hormone. But toward the end of the pre-designed 4 years follow-up, looks like the orange line goes up again. The event increased again. So making the investigator unsure about what the long-term, what direction this is going, so they decide to observe the study longer, prolong the study to 6.8 years. So from that line, you see, for women with already have heart disease, you should not start hormone as treatment or as prevention for further cardiac event. So you should not use hormone replacement as a secondary prevention. So by 2002, it's pretty clear that when a woman, especially elderly women with established coronary artery disease, you should not start hormone. But oftentimes by that time, they already passed the perimenopausal symptom. The thing that makes you want to start hormone probably is their bone health. But by 2002, we all know that you should not use hormone. You may use something else for the osteoporosis. Then the Women's Health Initiative it's 10 times, it's a bigger randomized trial, and this one is 10 times more women compared to the HERS trial, and this is a primary prevention trial. So once upon a time, we all felt that hormone is good for women, doesn't matter with or without heart disease, and that's the nurse health study, and the women are younger. And then HERS happened. We know when elderly women with heart disease should not start hormone. But then this happened. After we know secondary prevention by hormone is not good, then we want to know what about primary prevention, women who never had an event. And this Women's Health Initiative actually is 2 trials. One is estrogen with progesterone for women with intact uterus. The other is estrogen alone for women already have hysterectomy. And even compared to the placebo group of these 2 trials, the baseline health is different. Women in those days with hysterectomy, oftentimes they have some uterine disease such as fibroids. That group has more minority and they have overall poor baseline cardiovascular health. So remember that these 2 trials are really not the same in the baseline. The HERS trial, the average age is 67, and the women's health is average age is 63, and still about 10 years or beyond after, on average, after perimenopausal symptoms started. The primary endpoint is non-fatal MI or cardiovascular death. But this, compared to HERS, has added a safety outcome. Just in case cardiovascular health is still can benefit from hormone or estrogen replacement, what if a woman has more breast cancer, then you need to stop. And there are other global index of risk too, such as stroke, pulmonary embolism, colon cancer, and hip fracture. So this trial tries to answer more questions compared to HERS, which is a secondary prevention. Because this is primary prevention, they never have documented heart event yet. So you want to study more effect of the hormone. So women who are randomized to the hormone replacement, which is a combination of estrogen and progesterone, have a higher hazard ratio in heart disease, stroke, and especially in venous thromboembolism. But their fracture rate is reduced. Anything less than 1 is good for you. Anything higher than 1 is bad for you. So the fracture risk reduced significantly while cardiovascular risk, including venous thrombosis, increased significantly. So you should not use combined estrogen and progesterone for primary prevention. And this is the curve that, again, the first year you have much higher event and gradually it just drops. But still the whole course, the women with treatment of estrogen and progesterone had a higher risk compared to the blue line, the placebo group. But when you stratify or divide these group of patients or women with by their ages, or which is the year since menopause, you will see that if you start the combined estrogen treatment before they haven't seen hormone for 10 years and give them back, they actually have a smidge of protection to their cardiovascular health. But when they're more than 10 years haven't seen the hormone, you give them back, you increase the risk of event. So that's a primary prevention trial. So still have a question about younger women, what to do with them. And this is the absolute risk. So in this, per 10,000 person per year, the absolute increase of heart disease is 7. Stroke 8, PE 8, invasive breast cancer 8. But because colorectal cancer reduced, so overall cancer is a wash, the risk. And the hip fracture reduced significantly. Overall, the event is higher. So what about the estrogen alone? Because we know the progesterone mitigates some of the benefits of estrogen on the vessel, on the lipid and the endothelial integrity. The trial that are on women without uterus who have a higher baseline in the placebo group, have a higher baseline cardiovascular disease. Study group arm that has estrogen, they actually have a lower risk of heart trouble, although the stroke and thrombosis, venous thrombosis, is still high. So we have even more question now. Younger women, if they don't have uterus, should they still receive estrogen alone without progesterone for primary prevention? So even in 2002, we all know we should not start hormone for women with disease. We still don't know what about primary prevention and what about younger women. And when you stratify, when you look closer to the age of women, which is a reflection of how many years they haven't seen the hormone. If they're young, they haven't seen the hormone for only a short period of time, the benefit is significant. The protection of cardiovascular system is still significant in the estrogen alone trial. But when they're older, so still we are thinking that perhaps it's not just the hormone, but the woman's cardiovascular health itself, the baseline arterial health, probably determines more than, determines their future event more than the hormone itself. So that's the time when there's some theory called timing theory, that when women are younger, if you give them estrogen or combined hormone replacement, when they're younger, they may protect the arteries by reducing lipids and by protecting them. But when they're older, they may harm, the hormones may harm the arteries by promoting thrombosis and pro-inflammatory process. So that's the theories. That means the vascular pathophysiology changes throughout the lifetime of a woman. So the conclusion of this Women Health Initiative is that the combined hormone replacement, when you use that for women who are older, they increase cardiovascular disease, but also increase the breast cancer. Whereas in estrogen alone, they do not increase breast cancer, and there's no detrimental effect on their future cardiovascular event if it's just estrogen without progesterone. And both groups reduce fracture, and there's a potential benefit in younger women. So here are the difference between the clinical trial, which is HERS and WHI, and observational data, which is the nurse health study. The nurse health study, hormones were started when women were having symptoms. They want to use hormone because they can't help it. The symptom is so bad. The clinical trial, they deliberately not to enroll these women with symptoms in order to avoid crossover. But when they enroll older women, at least 63 years of age, the time since menopause, they haven't seen hormone for a longer period of time, and they're heavier, because when you don't see estrogen for so long, the fat distribution is different, and the insulin resistance increases, so the body weight is higher when women are older. So the baseline is different in terms of age, in terms of how long they haven't seen hormone, and their body weight. Compare this to the observational and nurse study and the randomized trial at the hormone and the Women Health Initiative. The younger nurses, when they start hormone, they have a significant reduction of cardiovascular health. Anything on the left side is good, on the right side is bad. So women who already went through menopause for several years, older women at the Women Health Initiative, they do not benefit, and they actually had more event compared to women who do not have hormone replacement. But remember, when you use estrogen alone without progesterone, the damage or the increased event in the heart is actually not significant. It's the stroke and the venous thrombosis. So this is the timing hypothesis. Estrogen may slow the development of atherosclerosis by improving the lipid profile and endothelial function. But when women are older, they trigger cardiovascular events through prothrombotic and inflammatory mechanisms. And these hypotheses actually was studied in non-human, in mice, and later actually reproduced in apes too. When you have you remove the ovaries of mice, then you feed them with very thrombogenic, lipid-rich food, and observe mice iliac arteries. If you give them hormone back, as soon as you take away their ovaries, they have a much lower rate of plaque buildup with time. So when they are just lost their hormones protection, you give them back, and before they have iliac artery disease, the hormone protects them. Without hormone, plaque buildup is faster. But then when you have a group of mice that already have cholesterol buildup in their carotid and aorta, already have established lesion, and you give them hormone, no matter in the aorta or the carotid, the hormone causes more plaque buildup. So at the end, Dr. Joanne Manson, the study investigator, when she has some money left over, she really wanted to know what happened if women are younger and only receive estrogen, because it seems that estrogen is pretty benign, especially in young women. So she used a marker as a coronary artery CT calcium score, and using calcium score to see if they already have some mild plaque buildup but never had event and they're younger, using estrogen alone, what happened. And they're actually, the result is pretty good. The calcium score is lower in the estrogen treated group compared to non-estrogen group. Then that's in younger women. So at the end, we know that younger women, if they really have symptoms, then it's actually safe to give them hormone replacement. Not just say that if you have to use the hormone to reduce your symptom, then you have to take the risk of dying. You don't have to say that. It's really safe. to use the hormone. Otherwise, they would just think that, okay, everybody saying hormone is bad, maybe I should just tough it out, but God is so terrible, so I have to take a hormone, but I'm actually killing myself every day. So you don't have to, when you go through the details of the data,